Hello, everyone. I'm Noor Mardam, Communications Associate at Mentor Arabia, host of ISSUP Lebanon chapter. First of all, I would like to thank you for joining us. We are pleased to have Dr. Maya Bizri with us in today's webinar entitled National Trauma and Substance Use Lessons Learned from the Lebanese Crisis. Maya Bizri is a clinical assistant professor in psychiatry and psychosomatic medicine. She is the director of consultation, liaison psychiatry, and director of the Psycho-oncology program at AUBMC. This webinar comes at a very crucial time considering the dire situation in Lebanon. With the quadruple crisis that hit the country over the past years, the Lebanese population has become at a higher risk of addiction. We discuss lessons learned, challenges, successful and failed strategies, and primary prevention. In this webinar, we will learn about disaster psychiatry in everyday practice, prevention strategies, what works and what doesn't, and the learning points for the next big crisis. Please note that we will have a Q&A session at the end of the webinar, so please feel free to submit your questions in the questions box. Maya, the floor is yours.
Thank you, Noor, for inviting me and for the glorified introduction. I'll discuss briefly how the national trauma affected substance use in Lebanon, but mostly what we learned over the past 2 years, because as you all know, the Lebanese crisis is still unfolding. I think we should call it the Lebanese crises, because we have many crises at the moment. And I'll discuss how that translates into psychiatric practice, but more specifically, addiction practice. So to start off, I have no conflict of interest whatsoever, except that I'm a psychiatrist. And the outline, as Noor mentioned, I'll first touch briefly on what disaster means, because in terms of especially talking about population health, I know you guys are all familiar with the term, but I just wanted to go briefly over it to show how that vastly, whether you're talking about substance use or something else, how that general ambulatory psychiatry, and the implication of the Lebanese crisis on substance use disorders, things that are particular to Lebanon. And then what we know in general, substance use disorders in Lebanon, you'll see that we don't know much, which is one of the big challenges that we have. And then I'll go over, which I think is the more interesting part, we'll go over anecdotally what are challenges we faced, how we had to adapt, how we had to change strategies, and what are proposed solutions for the continuing crisis and for the best way to provide. So disaster psychiatry, I just wanted, how is disaster psychiatry defined in the literature? Well, you want to think of disasters as community-wide events that result in collective trauma and substantial losses for many people at one time. What is most important, what I find interesting is, traditionally we used to think of disasters as a hurricane, a wildfire, a flood, and we have a lot of literature that talks about that affects mental health outcome. And up until very recently, we never really thought about pandemics as a disaster situation, because the last one we had was the Spanish. Particular to Lebanon, we have many other things on top of the pandemic that I'll discuss. But what we are projecting in the literature in terms of disaster psychiatry is mostly known from things that are non-pandemic related. So the interesting thing about the past 2 years is that everyone was writing their own literature on the topic. The most interesting part about disaster psychiatry, which I find interesting, is that inherent, and you want to keep this in mind in the lecture, is that inherently you're working in a low resource setting, because by definition, a disaster creates demands that are exceeding the coping capacity of the community. So inherently, not every intervention, we know a lot of interventions work in addiction medicine, but because you're working in a low resource setting, this may not be the best intervention resource setting, because you just might not have enough people to provide it. So we know that group therapy works, we know about preventing relapses, I'll talk about these specific things, but we might not be able to provide them when you're stretched out in terms of the healthcare system that we have. I just also want to take a moment to make a distinction in terms of terminology used that vary by country and by agency for those interested in reading the literature on this. In the US, the term disaster behavioral health, mental health had gained, it was very popular ever since 9/11 actually, but it's not exclusive to the US. If you're reading global medicine or global mental health, you'll see that the WHO or the interagency the interagency standing committee will use words like mental health and psychosocial when they're MHPSS is not an easy acronym, but we'll discuss it when they're talking about frontliners providing mental health support in emergencies. So just for those of you interested in reading the literature. And so post-disaster, what we know about post-disaster mental health outcome is that regardless of the type of disaster, are prospectively moving forward linked to numerous behavioral health, but also mental illnesses. And these are different. I'll talk about how these are different. So post-disaster mental health outcomes, so disasters will either make existing diagnoses worse or will lead to new onset common mental health disorders. These are commonly depression, anxiety, importantly, PTSD is a big one, onset or exacerbation of substance use disorder, which is our topic today, and for those that have suffered the loss of loved ones, bereaved grief disorders. You also have an increase that post-disasters, such as increased use of substance use, like tobacco, we tend to forget about tobacco, and drugs or marijuana, which is the major one. Post-disaster, and importantly, when we talk, because this is talking about primary prevention, you have to address both things, both the post-disaster behavior, but also the post-disaster mental health outcomes, because they inherently affect each other. What this means is that we know that patients post-disaster depression and anxiety will smoke more cigarettes, will drink more alcohol, will smoke up more cannabis than those that don't have mental health diagnoses. But conversely, those who engage in post-disaster smoking, drinking, but are without a mental health diagnosis are more likely to develop mental illnesses. And this is true for all types of disaster. About specific disasters in Lebanon, but this is true for everyone. So when you're talking about prevention, primary prevention about for addiction, you want to address other things, primary prevention of depression, primary depression of anxiety, primary prevention of PTSD, but also primary other behaviors without a mental health diagnosis. So even if it's just smoking. Now, just to complete my introduction, and I won't go over this in details, there have been fortunately many interventions that have been developed when we talk about standardizing interventions that are effective, developing toolkits that can be used globally for communities that are in crises. And this intervention pyramid, if you've read a bit about disaster medicine, you'll see this very commonly used. It's the international standard for MHPSS delivery. And it bears discussion, especially that we are talking again about primary prevention. And at each level, I want you to try to keep in mind the Lebanese experience. What Noor mentioned was the Quadrupled Crisis. So just for those of you that are not very familiar with how things unfolded in Lebanon, we've had decades of political turmoil, but more recently, it started with the economic financial collapse in 2019. And then we had political conflict after that. We had a revolution, some instability. COVID in March 2020, that was our first wave. And then we had the August blast 2020, the Beirut blast in August 2020. And I'll talk about the consequences of that. And then after that, we again had a continuing economic crisis, still ongoing, but we also had a second wave that was worse than the first one. And so you want to keep all of these in mind when we talk the interventions that are necessary in terms of primary prevention. In fact, this is really a purely population health structure that says we can do for an entire population as a platform for ensuring or safeguarding mental health for the entire community. So at the base of the pyramid, interventions, I'm not sure if you can see my mouse, but at the base of the pyramid, you have those practical interventions. That means restoring political power, rebuilding damaged buildings after the blast, for example, establishing clean water, providing fuel. That's a big problem that we have in Lebanon. These, even though they're not directly providing nutritious food supply in terms of food insecurity, which is a problem we currently have in Lebanon. So although these are not mental health focused directly, they are actually the underpinning for community mental health. And so if you don't do what this means is that if you don't target these, nothing from the top level tiers that you do, interventions up there, will be effective in terms of mitigating mental health consequences in crises. So at the next from the bottom, again, I'm not sure if you see my mouse, we look at strengthening the community and family support. If you think about the crisis in Lebanon, for example, those quarantining during the COVID pandemic, for getting children back to school, people that have lost their jobs, supporting family members who are to get back to work. And then the top two tiers are focused person-to-person, non-specialized supports and specialized services. The actually more mental health focused, these are direct interventions. I want to focus on the focused ones, the second one, not the top tier, because this is where we provide psychological first aid. These are people that are not necessarily specialized providers, meaning they're non-psychiatrists, they're non-psychologists, that are trained to provide psychological first aid in low resource settings. When we talk about low resource, you want to think about low financial resources, but also resources. And then we have actually the specialized services, and I promise you this is the last slide that talks about disaster psychiatry. But this is a type at the top level of the pyramid. So for patients who do actually develop psychopathology that is diagnosable, where you need a specialized mental health provider, whether a psychologist or a psychiatrist. And for that, training takes place globally. So on the MHGAP, I'm not sure if you guys are familiar with the MHGAP, I think you are, but that's the program that has a subset that is for humanitarian intervention guide put together by the WHO and the UNHCR. I say this because for the longest time, we used to think about how can we standardize globally a low resource intervention that actually works and that is actually effective. We know what works if you have high resources. That means we know all the types of therapies, all the types of group therapies, things need a lot of resources and support. Hello? We have very little evidence that supported what work and how we can standardize it on so that it translates directly on different types of humanitarian emergencies. And so these are very specialized materials used by mental health providers to train their peers that are non-mental health providers to provide specialized care. As an example, if you look at the modules within it, you adapt it to specific diagnoses. So there's a module on PTSD, one on substance use, and it really is translatable into everyday practice globally in every country, regardless of the type of disaster. And it's adopted in Lebanon by the mental health program, by the program at the Ministry of Health. So Lebanon in recent years, for those that are again unfamiliar with it, so for decades we've had political turmoil ever since the Syrian conflict in 2011. We've had a surge in the number of refugees. I wanted to mention this specifically because you'll see in a bit when we talk about data. We know for a fact that refugees are a population at substance use disorders. They use different substances. They are at higher risk. And unfortunately, they don't necessarily always have access to not just prevention, to treatment options. And so these are particular this is like a particular challenge that we face in Lebanon and that we continue to face, is that we're not providing, it just increases the healthcare disparity. We're not providing the most treatment we can to everyone that, in terms of addiction treatment, because we just don't have enough data on it. So there was a severe economic collapse in 2019, followed by political instability, the COVID pandemic as of March 2020, and the Beirut blast left around 200 dead, 5,000 injured, and at least 300,000 homeless. And I wanted to mention the type of injuries here, because you have, so the most common type of injuries range from skin lacerations to traumatic brain injuries. Because there's, I'm mentioning this because there's ample evidence. So going back as a specific situation, not just as a disaster due to economic turmoil or to political turmoil or to the pandemic, but there's a suggests that TBIs, or traumatic brain injuries, organic brain injuries, lead to increased vulnerability to addiction. And I'll talk about this in a bit. This becomes relevant to Lebanon, a country with an overwhelmed healthcare system baseline. What Noor mentioned, I'll mention here as Quadrupled Crisis, because it's possibly the breaking point that will worsen the epidemic of substance use disorder. I say this conservatively because as an epidemic, we anecdotally know that substance use is on the rise, but the data that we have is just, and we have to do a better job at collecting data on this. So substance use in Lebanon, I put here a summary of studies investigating substance use in Lebanon over 2 slides, and you'll see that there are not that many. This was recently published by the department here, and we took a look at what we know about substance use in Lebanon. And it just briefly, I don't think you can see my mouse again, but I think just for you to keep in mind what we're discussing, I won't go into every study, but you'll see that the population that we're talking about is very limited. We know about inmates, incarcerated people that are already using substances. You'll see 57 of participants use drugs in prison. The other population that we have access to, who is a very high-risk populations, are adolescents and students. And the population that we have access to in terms of collecting data on are also very worthy of a mention. And to me, I think this is an important group that we tend to forget about, our healthcare workers, medical students. These are at higher risk, especially with increased rates of burnout. In humanitarian settings, there's also the added factor of moral injury, and I'll discuss it. So despite the anecdotal rise, again, we have the nationwide statistics about substance use in Lebanon are very, very limited, sadly. Commonly misused substances, I'll go briefly over this. So one of the most commonly seized drugs in the country is cannabis. The geographic location and climate of Lebanon, we have a valley called the Bekaa Valley. It makes it naturally advantageous to cultivate cannabis. And it's very near the border, so it's trafficking. Other commonly consumed substances include opiate derivatives. I don't want to say we don't have an opiate epidemic, but it's not necessarily as severe as the global opiate crisis. Cocaine is one. Amphetamine-like stimulants are commonly used. I actually, anecdotally, during the COVID pandemic, we had a situation AUB where a patient was being given Captagon, which is a common street name for an amphetamine-like stimulant that is very commonly used in the Middle East and mostly in Lebanon. Recreational parties. Recently, smoking salvia, which is a psychoactive plant, has also been on the rise in Lebanon. So it's mostly cannabis, stimulants, salvia. I don't want to say we don't have an opioid epidemic because synthetic opiates are used, but it's not as severe as it is elsewhere. So in terms of thinking of harm reduction plans, of targeting specific populations, you want to look at the substances that really take everything from the West and apply it here. challenges that we faced, a lot of them. So I'll talk in general about healthcare system related challenges in mental health, because we do have many baseline that have worsened in the past 2 years. And then I'll talk about specifically addiction related challenges. We have, this is a recent report by the CNN, if you see it about the medicine shortage in Lebanon. Medication shortages have been ongoing for the past year, if not more, and patients are really suffering from it, including oncology medications, chemotherapy medications. We have a national psychiatric bed shortages. So this, in Lebanon, we have very few psychiatric wards compared to the number of hospitals in the country. And only one of them is considered a governmental, so accepts governmental non-private psychiatric ward, a psychiatric hospital, what is considered a psychiatric hospital. And you want to keep in mind that that hospital stopped accepting admissions during the COVID pandemic. So you want to think that people, if you wanted to be admitted during the COVID pandemic, just an addiction issue, any psychiatric issue, you had to pay out of pocket, most likely. On top of that, the August blast destroyed few psychiatric wards that we have in Lebanon because it damaged 2 main hospitals. And due to the COVID pandemic, psychiatric wards, for example, at AUB where I work, we had to close down our psychiatric ward because we had to COVID beds, and we had to relocate to a smaller unit. So we started, I have around 13 or 14 beds, and now we have 4 beds that are psychiatric wards. So there's an increase automatically in admissions that are either in the ED and that board in the ED for psychiatric patients, or that get, the emergency room, or that get admitted to a regular medical floor. And I'll talk about how that translates into ambulatory, what we've had to do to take care of these patients. It is a massive exodus of healthcare workers. So in September 2021, the WHO estimated that nearly 40% of Lebanon's doctors and 30% of its nurses had departed since October 2019, over the past 2 years. We are still one of the few countries that has no national mental health policy or act. We have a program, but we don't have an act. And we've never had, even before the crisis, we've never had a real mental health coverage of outpatient medications, of ambulatory visits to doctors. So mostly these were out of pocket. And this was, in general, these are the issues or the challenges that we face in terms of providing general psychiatric care. When it comes to addiction, that's compounded. There's the obvious relapse risk that is a challenge for patients that are in remission, but there's also the medication shortage. This is a tweet by one of our colleagues who unfortunately fell, where he reports, so you guys are familiar with Suboxone substitution programs that has really kept opiate addicted patients or heroin patients who used to use heroin, for example, that has really kept them safe for over 10 years in Lebanon. And if you're familiar a bit with addiction medicine, you'll know anecdotally the odds, if you're a chronic heroin user or an opioid user, the odds are stacked against you to go into full remission and not to relapse if you're not on some sort of substitution program. In Lebanon, we use buprenorphine, we don't have it. And so this ran out this past, I would say in September or October, we stopped having it. And so what people were doing is they would start supplementing either with opioid and relapsing, or they would start weaning themselves off so they don't completely, which is not as effective as it would be otherwise. Financial stressors, this is an important one. Because of financial stressors, people who stopped cold turkey. And so that we had a huge increase of withdrawal presentations to the ED, to the ER, people presenting in withdrawal symptoms, or people that were admitted with symptoms to a medical ward or a surgical ward, and where the primary team were not usually very familiar in dealing with withdrawals in present patients. Patients sought substance replacement. So I have a patient, he's not my patient, but a patient that I saw on the wards, on the medical wards, that used to use benzodiazepines and alcohol. And if you're familiar with addiction medicine, you'll know that benzodiazepines are alcohol in a pill. And so when he ran out of the medicine, he used to abuse them, he started increasing automatically his alcohol, significantly so. And he presented in a post-operation where they, they wouldn't give him obviously any supplementation because no one had asked about it. And I'll tell you how we introduced screening to start detecting these cases more. And so he became very delirious. And again, this is a very serious case because delirium tremens, or the effect that happens, which happens in alcohol withdrawal, can be deadly in up to 20% of the cases. Lack of data, another challenge is that we don't have access data or screening to a large population at risk, including refugees. So we really cannot say that we can provide adequate care without collecting data or accessing these patients. People with traumatic brain injuries, you want to remember that the blast left a lot of people with traumatic brain injuries, have what we call frontal disinhibition syndrome. So the frontal lobe is the part of your brain that really keeps things afloat, that really, these are the brakes for your behaviors. And so when I say disinhibition, is that these people become, have a higher risk of addictive behaviors, all sorts of compulsive. People that have physical injuries due to the blast and pain and develop pain syndromes are at higher risk of starting to self-medicate and using substances. So this is where you can see an increase in iatrogenic or medication-induced opiate use. And and healthcare workers, these are another challenge. There's a strong correlation between burnout and substance misuse. And we have a high rates of burnout, we have higher rates of depression, but we also have a high rate of moral injury. That's globally in COVID, but more so in Lebanon, where there's a moral distress and with the ethical dilemma of not giving right care to the patients. So to the interesting part, I think that's interesting because we've had to adapt as we went along with the. So I'll discuss briefly what are things that we learned during the past 2 years. Well, first, as a psychiatrist or a mental health provider, as a provider, you learn that you don't have to see everyone because you simply cannot see everyone. What that means is that you have to put in a stepped care system, which is very striking and very contradictory to things you would do in high resource setting or in non-disaster settings. The system of delivering mental health intervention so that the most effective yet least resource draining treatment is delivered to patients first. And you kind of have to ethical dilemma here because you know that you can be providing more evidence-based treatment, but intervention, but you just simply don't have the resources to do it. So what stepping up means is that assessment and basic management are done by primary care and lay personnel. You step up as clinically required. Stepping up meaning ambulatory psychiatry visits are only reserved for either high symptom severity or risk of harm. Otherwise, these patients are taken care of in a primary care settings or even by trained nurses. And I'll talk about another concept here that we introduced, which is task shifting. Screening. I can't say this enough. I can't emphasize this enough. This is tricky because what this means is that you really, if you're the primary care team, you really have to make sure that you don't miss out on high-risk cases, which are high-risk behaviors in terms of self-harm, harm to other, psychosis, but also substance use, because you don't want to miss out on substance use or the withdrawal symptoms. Screening has to be Sorry, I have to turn on. Screening, caveat when you're doing screening is you can't just go on Google and pick up what they do at the University of Chicago and decide I'm going to use the same screening they're using in their COVID, because at some point everyone is treating COVID as a disaster psychiatry. Everyone is stretched out and is working at full capacity, every healthcare system in the world. But you can't do that when you're talking about psychiatric screening, because you have to pick validated screening, meaning screening, it's not just about translating words, but it's also things that have been validated in the population that you're working with. So we kind of had to work with what was validated already in Lebanon, and that already narrows down your list of available resources to screen to a handful. And so it has to be targeted, meaning, and that there's a caveat here, meaning you have to not miss out on things, make sure you capture the serious things, the very high risk things, but you also want to have targeted that is specific to at-risk population, because you just simply cannot screen everyone for everything. A brief screening. So before, and I'll talk about the screening we did here, frontliners, meaning the nurses or the patients in the or the frontliners in the ER, or people that are the first point of entry of patients into the system, are already overburdened. If you're adding a screening that takes half an hour, they will just simply not do it, which is something that we faced as a problem. I'll tell you how we managed around it. So it has to be brief enough, it has to be validated, it has to be targeted, it has to be highly sensitive for high-risk behavior or psychiatric emergencies. Remember, you're delegating these tasks, and these are sensitive questions that not everyone is comfortable asking, because not everyone is trained to ask. We're delegating to non-specialized clinicians. So you want to make sure that you don't actually miss out on high-risk behavior, including addiction, but you also want to be specific to vulnerable. Ask a teenager and an elderly the same questions, because the questionnaires or the tools are different. So what we did, this is not my picture, but this is a picture from our consult liaison team. I'm a consultation liaison psychiatrist, so that means I am a psychiatrist for the medically ill. So I actually see the psychiatric consults on medical and surgical wards. Usually, traditionally, you think of substance use as an outpatient setting, but in disaster settings, I'll talk, in Lebanon specifically over the past 2 years, I'll talk about how that kind of transitioned into an inpatient setting. So our own experience with screening, we used to have, this is something, yes, I removed the name of the patient. So this is a type of screening that is done in a healthcare system. And when the patient enters, what used to happen before we introduced our screening, there were these flow sheets, these screening tools, except the psychosocial screening used to take around 40 minutes because you had to fill all of these questionnaires. So a nurse that is taken, that already has many patients, what ended up happening, they would just not fill it. And the charts would be deficient, because they were so burdened with taking in everything else, their medical history, their family history, their acute presentation. And so these are patients that are presenting for medical and surgical reasons. And so what happened is, or for COVID-related reasons to the family physician. So what happened is we had to really make it an extremely brief screening. And what we did, which I think is very cool, is we picked a brief screening that would trickle, that if positive, would trickle down, would trigger like a cascade of a more intensive screening. So you had to fill out as a nurse on assessment, and then if one of those would cascade, or it would lead to a more specific questionnaire. And that was very important in us detecting withdrawal in many patients, and I'll talk about how we did that. So required within 8 hours of admissions were alcohol and drug screening, behavioral screening, self-harm screening, and neglect of and abuse. And I'll go briefly over each one of those. So this was the required documentation. Neglect and abuse assessment of task shifting in disaster settings. Traditionally, historically, when that if in the old assessment, what we used to do is detect possible neglect or abuse, automatically that would lead to a psychiatry consult. That when that started being mandatory, that would take another hour out of the psychiatrist's time. And so what we did is we said, you know what, there are social workers that are, if not as good, if not better trained in this, that can detect neglect or abuse and then can do just as good of an assessment. And so instead of the psychiatry resident going, and if they have like 10 consults a day and putting an hour into this, it would have to go through the social worker first, and that would be referred to us if there's a clinical need for that. If neglect or abuse is identified, we changed it so the next step action plan would go to a social worker consult. So this is a shifting when you have very few resources. And then we introduced a BPA. What that means, it's a best practice advisory. So for these to make sure that we don't miss out on these, if you had a high risk of alcohol withdrawal or substance use withdrawal or suicidal patients, it would automatically force the physician to, it would prompt the physician to place a psychiatry consult. So we make sure that people, remember in that pyramid, people you step up with severity, people that have severe presentations would automatically get specialized care. So make sure you get specialized care is reserved to those that need it the most. So again, we do a drug screen. I'll go over these. This is based on nurse assessment. So you do a drug screening, and if that screens positive, then that would trickle down alcohol screening. The Audit C is what we use usually. It's evidence-based and it varies depending on gender, based to see if the patient is at risk of substance use. And based on your score, it would prompt a psychiatry consult. But more importantly, once the Audit C is filled, you would automatically be screened as well for alcohol withdrawal, which really patient based on nursing assessment, patient is at risk for alcohol withdrawal, please consult psychiatry team. If you look down, if you do not order and a patient consult a psychiatry, you have to justify it. So you can't close the chart without filling out these. We also introduced, I'm sure you guys are familiar with the CWA. This is a scale that puts a score on alcohol withdrawals. So the consult team actually trained medical and surgical nurses along with chief residents on surgical and medical floors to, I'm almost done here, I know I'm running out of time, to detect alcohol withdrawal and to start treatment based on that. So based on we held training sessions where trainers would train, I think I'm saying it right. And then based on that, a medication protocol would cascade automatically. So this is another example of task shifting. You delegate, even though you're supervising this, you do delegate these to other parts. So you work as one team, other part of the multidisciplinary group. More specifically, after the Beirut blast and the COVID patients, well, what we did is, in terms of disaster psychiatry, you kind of have to switch to a crisis intervention, and you can't keep giving everyone the services they need, ambulatory services. So all on-site activities and outpatient face-to-face clinical services were kind of paused for a while in both events, especially during the lockdowns, and we had to switch gears very quickly. We did the crisis intervention services and triage services that were designed, that were implemented. And what was nice is that we involved interns, psychiatry residents. In terms of task shifting, you're kind of switching people that have lower training. You're giving them specific tasks. But the key here is that if you want to do that, you kind of have to carve out the tool to supervise them, because that would provide adequate care, that would make sure that they're providing quality care. And these, we had to apply We'll talk about telemedicine later on, protocols, and triage assessments for people affected by the quarantine and the blast, by the quarantine. The PHQ-4, you'll see how it is 4 questions. That was the screening that was done. It doesn't take much to apply it. It is validated in Lebanon. It's very brief, and and this was the one that we used. I talked a bit, going back to the SIWA and to screening medically ill patients. I talked a bit about how we had to reconceptualize substance use disorder as an inpatient diagnosis. So traditionally, we think of addiction as an outpatient thing. You know, you just go into the hospital for detoxes, but most of your treatments, or if the patient, there's a saying in addiction medicine, you meet the patient where they are, meaning if they're not ready, you can't push them into trying to get treatment. So they come to you as opposed to you going to meet them. And that kind of changed here, because what happens is, so most people can't necessarily afford an ambulatory psychiatric service anymore, even though we do have a low fee clinic, but not a lot of people can present due to financial constraints, fuel constraints, commute constraints, COVID constraints. And so what happened is a lot of the load became on the consultation service, because these patients withdrawal, they were presenting to the ER, they were presenting with medical, and if you notice, we collected the data over the past 2 years, almost a year and a half, of the consult service. So any psychiatric consult, anyone coming in for depression, anxiety, and 13% were substance use cases. So that tells you that a huge load of our 13%, yeah, and we're talking about 200 patients almost. And so you cannot just miss out on those. You have to kind of switch gears and start to think of substance use as an inpatient diagnosis. The opportunity is there to provide quality mental health services while the patients are hospitalized, including enhancement, which is something where you motivate the patient to go through this next stage of change if they want to go into remission or get treated. What I will say as well is, if you want to provide, what the lesson learned here is that you have to tailor your data collection to provide for your population, your specific population. So notoriously, when we started looking at places we're doing worldwide, most people will talk about the opioids and narcotics, especially in cancer patients. Cancer patients are about 25% of our consult service. And so what you'll see here is patients, 12.3% of patients without cancer use narcotics with 12.3% of patients with cancer, this is with cancer, use narcotics, compared to around 40% of patients without cancer. So patients without cancer are more likely than population in our sample than patients with cancer to use narcotics or opiates. The global, among cancer patients, globally, the misuse is 7%, 8%. In our population, it's only 2%. So you'll see that the opioid epidemic is largely an American, well, it's not an American thing, but it's not something that you can import from the West and apply here. Not all interventions can be imported and applied because they don't necessarily fit the profile of the population that you're treating. So we really have to do a better job for the disaster or for the continuing disaster of tailoring our data collection so we can really provide adequate care. I talked about this a lot. Task shifting, service delivery. It's along the same lines. It's shifting, it's the rational redistribution of tasks among health workers, where specific tasks are moved from highly qualified staff to staff with shorter training, either residents or nurses, and fewer qualifications. This is actually to cut the healthcare disparity, because those who can't access specialty services still get adequate healthcare. The goal is to preserve quality, so psychiatrists here see complex cases, and other primary care providers can help in everything from identifying disorders, diagnosing, managing basic symptoms such as panic attacks, and in primary prevention, preventing them from going into addiction. This is timely because of the shortage in psychiatrists, the waiting list just is huge. Again, the crucial point here is that these tasks need to be supervised by a senior specialized psychiatrist. So if you have a resident in the family medicine clinic addressing basic mental health needs, you really have to do supervision at least once a week. The task can be limited to a specific task only. So suboxone delivery, motivational enhancement, in addiction that could be relapse prevention can be done by a non-psychiatrist. What we did in terms of task shifting is that we, psychology interns and psychiatry residents, applied phone screening protocols and triages, but also they provided, and in terms of telemedicine, we provided daily individual online therapies to patients that were either quarantining or that had lost a family member. During the pandemic and post-blast, this is another concept of what we did. You have to actually put on your crisis intervention hat and switch off your ambulatory general psychiatry hat. So shortly or 2 weeks after the explosion, the department here launched the trauma assessment. It was staffed by psychiatrists, by psychologists, by residents. It was free of charge, and it provided immediate mental health support, even if it was just a psychological first aid. It's a very short video.
The trauma assessment and support clinic was started 2 weeks after the Beirut 4th of August explosion. With the community using the specialist resources we have in the department, and to facilitate access for those who had not been in the psychiatric system prior to this situation. And so far, many of our therapists and psychiatrists and residents have been involved in the treatment and provision of support for this population.
We have been seeing many patients with symptoms serious enough to qualify as acute, and many others who are struggling emotionally, cognitively, physiologically, materially, medically, existentially, with going back to some kind of normal or even normal after the explosion. We anticipate that many of these cases will require follow-up, and that in fact we'll probably see many new cases as the initial shock and numbness of the explosion die down and people are left to reconcile with incredibly challenging losses and realities.
I want to talk about that because that's one of our failed strategies, but it's worked everywhere else. So, in low and middle income countries, as you begin to services forward in the faces of additional challenges, this is a review that we wrote on telepsychiatry in the Arab world, because everywhere else in the world there was a rapid deployment during COVID of telepsychiatry. If you think about it, psychiatry is the ideal place to start because it's the one that is most amenable to telepsychiatry, medicine that is most amenable or suited for teleconsultation. And it has helped remove many of the barriers, including travel barriers, commute barriers, financial barriers, but the implementation is still very poorly lacking in most Arab countries, including Lebanon. One of our failures is because access to reliable internet connectivity and electric powers is still a problem in many low middle income settings, including Lebanon. So I think moving forward, whether for any future disaster, you cannot plan without embracing telemedicine, because that's just the way moving forward. People will want it, and it's really very effective. If not as it decreases, sometimes people feel more comfortable doing it. But unfortunately, that was one of our failed strategies, honestly, because we always had breaks in electricity, in power. The internet is not very real. And so that's another example of how you can't incorporate a concept from the West and apply it in disaster medicine. Engaging, that's my last slide, engaging community stakeholders, this is crucial because, after the blast, I know many of you heard this, but after the blast, we had a lot of funding that came in for NGOs. after any disaster medicine, there's a disaster, there's funding that came. So you can imagine if you had 4 disasters in Lebanon, how much funding came. And most of it is channeled through NGOs. And they're the main drivers of psychosocial progress in low middle income countries. That is not the case in high income countries, where NGO funding is mostly used as seed funding and research in science. In low NGOs are not only advocacy champions, but they're also a trusted source of external funding. These are audited, external sources trust them, and so you kind of have to engage with community stakeholders. You can't function solo. In countries with high financial constraints, it is crucial to partner with NGOs. They can help you set priorities, mobilize resources, train staff, and they can help in capacity development of substance use, of specialized substances. For example, we had to partner with an NGO to be able to get, during the medication shortage, we now have established here a peer-to-peer fund where we have, and these came through an NGO. We have medication donations for our needy patients that can't afford medications, that either can't afford it or can't find. These are my references. Thank you.
Thank you, Maya, for this informative webinar. It was really, how do you say, like, I personally started seeing things from different perspectives, and it's really sad to hear what's going on in the country, really, in terms of mental health and psychiatry. And you're doing a great job, you and your colleagues at AUBMC and all the volunteers and social workers out there in the field. We will be moving to the Q&A session. We received a lot of questions, so thank you everyone for submitting your questions. I will try to go over all of them, but I know we are running out of time. So the first question is, I think you answered this towards when you were presenting. Has substance abuse presented with younger people during a crisis? And I think you mentioned that adolescents have been using more than before. Yeah.
It's interesting questions because notoriously adolescents are at high risk. That's the age of experimentation. Substance use, people that have a predisposition for addiction tend to develop it. Adolescents, you want to remember that the added burden of adolescents, we did a study on young adults, not adolescents specifically, so people between the age of 15 up until 21, 22, 23, and these were mostly students. Students had to change quickly to another we've never heard of before. They had the COVID. You want to put on that in an online platform where studying is always with an unreliable internet connection. You were quarantined at home. You were afraid of being a vector for your loved ones. You were afraid you could not pay your tuitions because your parents' money was stuck in the banks. And on top of that, they had the added stressor. We did a study on students of having an uncertain future because they would not know if they could face employment opportunities when they graduated. So we did see an increased use of substances, mostly cannabis, not alcohol, mostly cannabis. I want to say that cannabis is relatively cheaper than other substances and more accessible for adolescents. Not so much in stimulants, but yes, we did see an increase in substance use, a lot actually. And these mostly present to the ER with somatic symptoms, vomiting, nausea, post-cannabis, and all of that.
Moving on to the second question. So due to the crises in Lebanon, it led to, as we all were all aware of, to a drastic poverty level. So how are the unprivileged people able to access the required care or treatment Is it through NGOs? Are hospitals doing like a volunteer sessions or workshops with them?
So that's a good question. Poverty comes with many layers. It's not just about the financial issues. You want to think that it's become with the shrinkage of physicians or of specialized care, you're getting, it's become more of an exclusive specialty. So really, it's those who can afford it pay for it. So the burden on providing care has been on NGOs that have developed mental health clinics that are free, but even those are extremely short-staffed. Their waiting lists are huge. I know we have a suicide hotline in Lebanon. If a patient calls you and that's the dilemma of the physician. If a patient calls me and tells me they're suicidal, I'm going to tell them go to the ED. I'm going to obviously try to de-escalate and tell them please go to the ED. If they present to the ED and they need an admission, there are no psychiatric beds. So really, if they can get care and get a psychiatric bed, if they get discharged, you're not sure they're going to be able to afford the medication or find it. And so it trickles down to many layers, not just accessing care. And so the burden has really been on NGOs. We have a low-fee clinic at AUB, but I'll tell you one thing. One of the main challenges in getting people to the low-fee clinic is the cost of the commute, because I don't know, I'm not sure if many Lebanese are here, but it costs a patient of mine to come down to pay a fee of 40,000, which is nothing right now, of 40,000 to Lebanese pounds for a visit, which is a low-fee clinic. It used to be an almost free clinic. Now they upped it to 40,000. It costs them 400,000. So that's half their monthly salary for one visit. And these are people that might not have access to internet. And when I talk about leveraging telepsychiatry, we offer telepsychiatry. Not a lot of people have access to internet. So if you want to provide adequate care, you can do it without the basic infrastructure. I mean, this is what we talked about in the beginning. This is what I mean, disaster psychiatry. You really have to target basic things. You have to work with NGOs on covering commutes. We have a fund that covers commutes for patients, just commutes.
Wow.
So transportation has really become an issue, and we're not a very good.
And at AUBMC, did you offer any basic training program for volunteers and community health providers? Like, did you work closely with an NGO to provide like a training program?
So we provided psychological first aid,
Okay.
but we have, I mean, there's a lot of liability that comes with these things. A lot of NGOs have done a very good job at it, actually. They were present on the ground in base camp post the blast. What we did is that our trainees had stuff. You know, these trainees, they have to go through several things to get accredited, and you kind of want to think that, for example, residents have 4 years of training. 2 out of those years of training were in disaster more than crisis intervention. I mean, they missed out on a lot of things, and they were just trained in providing psychological first aid, emergency psychiatry, disaster psychiatry, which is not the usual case. Okay,
thank you. You presented a pyramid while you're in your presentation, and one of our attendees is asking, how would you see the role of the community in that pyramid and the preventive measures? How can non-health care workers help?
So there are several ways you can help. Like I just mentioned this, Noor. I think the most important thing that would make a healthcare provider not feel like he's paralyzed in terms of helping patients is partnering with NGOs for basic infrastructure. So you don't necessarily, when you talk about partnering with NGOs, it doesn't necessarily have to be a mental health NGO. It can be an NGO, it can be an NGO that's helping with housing, which is a major issue. It can be an NGO that is helping with education, with providing clean water, food insecurity. So because again, in low and middle income countries, I think that's where the role of these are huge funding sources, and this is where the role of the community is most likely.
Okay, and we actually did see a lot of non-health workers coming down, especially after the Beirut blast, just helping on the streets, whether it's cleaning up, and at least in Lebanon, there's still this sense of helping the community and helping each other, which is good to see. Someone's actually asking for a comment rather than a question. In his perspective, substance use is soaring in Lebanon as the country is heading, is already headed with all these crises, political, economical, post-blast, COVID. So this is his comment, this is his perspective. Do you have any comment, would you like to comment on it?
That it's heading towards an epidemic?
This is his, he would like to hear a comment on the substance use. It's soaring because of all the crises that you mentioned. What is your comment on that?
I think we already did have a substance use. If you ask any mental health provider, they will tell you we have a substance use problem in Lebanon, even before the crisis. It's so frustrating because we don't have data that prove it. If you look at the suicide numbers in Lebanon, which took 2 years to build up the data, the statistics on it, we still have overdoses, years where the number of reported suicide due to overdoses is 0 or 1, which is nonsense. It's definitely more. So we don't have the data that says, if you want to go get funding for substance use outside, you want to tell them, this is the problem that we have, that it's very serious. We don't even have access to good data that can back up.
That's true.
But if you ask any mental health provider, and you can tell that in any, we call it the science epidemic because we just can't. And again, I mentioned something and I want to mention it again. We have a third of our population that are refugees. And these are very high, they use different substances. And access care is different than other people. And so you want to keep in mind that a lot of the missed substance use patients and the missed opportunities to actually provide care are among the most vulnerable. A lot of the reports from other countries show that, for example, inhalants in refugees are increasingly common, and these are very neurotoxic. They cause a lot of skin damage. We don't have data on that. And we know we have a lot of youngsters who are refugees, who are out there, and they're using inhalants.
That's really unfortunate to hear. I'm going to move on to the last question. So what kind of activities are you doing taking into account quarantine and social distancing? How do you manage your victim groups, whether they're perpetrators or perpetrated? How are you dealing with these activities?
So we actually presented groups. They didn't take off a lot, and when we investigate again, they didn't pick up a lot.
Okay.
A lot of people that came. Partly, it's not the stigma. People say it's a stigma. It's not the stigma. Partly because even with a group fee that is low, people still can't afford it. People can't come to the clinic. We have switched telepsychiatry. And I'm a big fan of endorsing telepsychiatry because there's really one side of medicine where you're going to apply telemedicine. It has to be behavioral. And there's a sense, we switched our outpatient groups. I think that's important. We have an outpatient substance use disorder groups that we have twice a week. We've switched them to telepsychiatry, like to Zoom. And people are showing up more with, pseudonyms. They're not putting in, like, privacy is even more.
Okay.
So people are really, and I think in psychiatry, telepsychiatry is the way to go. If you really want to, because there's a group of population that are otherwise hesitant to present for care that come in.
Okay, thank you. Thank you, Maya, again, for supporting ISSUP Lebanon and for this informative webinar. Many people are asking if the presentation will be shared. So I would like to let you know that it will posted on ISSUP.net on our website, where you can actually find the recording session of the webinar, as well as Dr. Maya's presentation. For our professionals in the drug use prevention field in Lebanon, please apply for a free membership on ISSUP's website to stay updated with the latest information. Please follow us on Twitter, LinkedIn, and Facebook to learn about our future webinars and activities. Thank you and have a good evening. Maya, would you like to add anything?
Thank you for attending. I want to make sure I don't make it sound all too grim. It's much better than it was last year. I think people, I think the conversation, I mean, a lot of people talk about stigma. I think the conversation is way beyond that. I don't think there's a stigma issue that is that severe. I think a lot of it has to do with access to care, and you don't have to take psychological first aid courses or specialized courses to be able to help in substance use disorders. It can be just social connectedness and infrastructure. Remember the pyramid. I think the pyramid is huge in disaster psychiatry. Thank you.
Thank you. Thank you, Dr. Maya. Have a good evening, anyone. Take care. Bye.